And now we move to the maestro himself. I think after almost 40 years of practice to us,
Yeah.
he's still refining his results. And he's the one who's taught cataract surgery to most of us and most people, directly or indirectly. Suhas influences everybody. But he is still improving his results. He's still refining cataract surgery results. And that is what he's going to tell us. The journey is still on.
That's the reason you can practice even after 40 years, because cataract surgery is so very interesting. It doesn't really bore you. Every time, if you keep your mind open, there are a lot of things you can learn and improvise. In fact, I was very late to come into femto. I always believed that I can do better, but after I went in for femto, I realized that femto takes your surgical level to another level. And of course, I'm a beginner there. I have to learn it like the masters that you all are. But now, thank you so much, Sandeep, and we go to my talk. Well, some of the things that I'll be showing you here are nothing new. Probably you all are doing it, or probably you have seen them done better. But I've just put them together. So with that, I go to my first case. See, posterior polar cataract. Uh, we have different ways of doing posterior polar cataract. I have my own way of doing, which I've been doing for a long time. What I call it is in situ 4-quadrant. Now, this is a situation where you're not doing a full hydrodissection, and you can't rotate the nucleus with a fear that the PC can rupture. So what you do is in situ 4-quadrant. That means you have to do a single trench, then you create trench on either side and weaken the girder. And once you have done it deeply enough, you can just go with the second instrument and just snap it. You don't have to use too much of strength here. So I go with the chopper and just nudge it down. It breaks there. And that way, each piece gets separated. And see, once your endonucleus is out, even if the PC is truly defective, it doesn't really hurt you much, because you're left with very little things to do. And with the PC defect, you're still easily able to take care of that. So, another thing which is a very old concept but not very popularly used is the AC maintainer. I cannot tell you enough about the fantastic strength that particular concept has. And especially in cases where you truly want your AC to be formed all the time, there's nothing like an AC maintainer. Today, AC maintainer is in its new avatar, like a trocar, thing, which is even better. But for the purpose for which we use it here, the conventional AC maintainer is good enough. The reason is here it helps you keep the chamber stable, especially in a posterior polar where you truly want things to be in control. Now the real problem comes here. You are at the final stage and you still want the chamber just to remain deep enough. And sometimes what happens, you have a PC rupture there and you have an AC maintainer there, and it kind of holds it. See, now I have my irrigation from the side, whereas AC maintainer is still maintaining it. Then I go with the second, make another side port and go with the bimanual on either side. But I still continue to keep the AC maintainer there, because when you want to change sides, that is the time you want the AC to be formed. Now, this is a case where the plaque is there, and there's no point in trying to scrape it any further, because the moment you try to do it, sometimes it can just give way. So what you do is you implant your lens, and after that you go with the cutter and create a central opening, because that you have to do, because or else the patient will never have that wow effect on the first post-op day. It is not possible. It's firmly stuck PC plaque. And that's a place where I do try and see if I can get, but otherwise it's the cutter that you do it, and that's it. Here, what I want to show you is there's always that kind of a question. There are some surgeons who implant a lens under the visco. There are some who do it under hydro, and the reasoning behind doing it under hydro is that it takes a lot of time to get your visco out. So I thought of a technique which is a hybrid technique, because when you the problem is when you do it under visco, there's a lot of visco that goes under the lens, and the problem is it takes longer time to get visco that is under the lens out. So what I do is, at the end of the surgery, when the bag is collapsed and the anterior capsule is flat on the posterior capsule, you inject very gradually. See, if you have noticed, when you inject and the bag starts opening up and the visco starts going inside, now you don't let those two flaps open up. Just inject a little, keeping the AC all the time shallow, but it is filled with visco. And after that, now watch what I do. What I have done before, I'll show you. So I just went with the visco. It had just filled the upper part of the chamber. I go at the irrigation from the side and fill the bag. Now the situation is the bag is filled with irrigation. On top of that is visco. And when the lens is placed, lens goes into the bag. There's hardly any visco in. And the amount of time that you need to get that visco out is also minimal. So that way you achieve your purpose. Now, this is another thing that I have started doing, because in some of the lenses, what I have realized is if the lens has a longer haptic, or depending on the material of that lens, after you have implanted and formed the chamber forms well, it's firm, but you can make out that the lens has not really gone deep into the bag. The eyeball is firm, but the AC is still shallow. Now, these are the cases post-op. They'll always land up with some amount of myopia. We were talking about distension. If the fluid stays behind the lens and the lens is pushed forward, then post-op myopia. Now, for that, what I do is this. It's a routine for me. The moment I have formed up the chamber, I know that it is. Check it again. It's very simple. At the end of your irrigation, with the second instrument, push back the lens, and you can actually see the lens going back and the AC deepening. So that's the end point. Dr. Tanvi was talking about that astigmatism, the case that she showed. Now, this is that case. When you have these RK patients coming, and if that RK are multiple cut RK with badly cut, the cornea will have so many aberrations that it's always a good practice to use pinhole pupilloplasty. Now, especially in eyes where astigmatism cannot be corrected with a toric lens, the simple technique is to practice pinhole pupilloplasty with most of your cases, because it gives you amazing results. And suppose, because of that pinhole pupilloplasty, patient has complaints of lot of poor vision in the evening, in low illumination. It doesn't take you much time. You just take the patient on the YAG laser and just snip it, and the pupil opens up partly or fully. So what you have to make sure, now in this case, the pupilloplasty is done with single pass 4th row, and on both sides, up and down. And if you want to go for a true pinhole pupilloplasty, it all depends on how bad the aberrations of the cornea are. Here I've taken one suture at the top and one at the bottom. Further, you can take even on the sides, because eventually, at the end of the case, you would want the visual axis to be seen right in the center. So sometimes if I don't see it, what I'll do is I'll use a cutter to center it. So yeah, so that was, sorry. Yeah, in this case, the patient achieved 612 with a simple lens, and the cylinder came down to almost 3. Well, today, those who have an access to femtosecond, the arcuate cuts, this doesn't mean much. But for someone who's always practiced limbal relaxing incisions, or for some of you who would want to refine your cataract surgical results, especially in premium lenses, LRI is a beautiful technique to add on to your practice. It's so very simple. In my practice, I do it at the end of the surgery. The chamber is formed. You're almost complete, except for that small cylinder that is left, or a cylinder that needs to be corrected. So you have to have the guarded knife. You can use the NAPA program, where you actually go by the corneal thickness that's there, or you go by standard 600 micron depth. I prefer to go by NAPA technique, where my results become a little more accurate, because if the cornea in the periphery is 550, I would set it to 90% of 550. If it's 600, I would keep to 90% of 600. So that way you can achieve those results. Of course, I'm sure this is nothing great, but still, if you want to refine your cataract surgical results, the time spent on peeling off those plaques at the end of the surgery make a huge difference. Now you would say uh, the center is clear. Why would you like to remove it? The reason is they are still there, and there's a depth to it. When the lens sits on it, they are there between the lens and the posterior capsule, and it definitely creates some space there. I would want the lens to literally stay flat, stuck on the posterior capsule, and to do that, you must have an uneven posterior surface, posterior capsular surface, and and sometimes what happens, what you see here as slightly decentered, in actual reality, when the patient sits on the slit lamp, you will see that the plaque sometimes is right in the visual axis. So you have two choices. You're putting a premium lens. After it, maybe you can YAG it, or if possible, you can always use your surgical. Sometimes when you do this, it also gives you that kick. Oh, I could do it. Sometimes you need, because in a cataract, otherwise is a boring topic. So if you want to really make it better for your own good feeling, then these are the small techniques you can do. Here, the cystotome that I use is a little different. Regular cystotome will have a tip which is bent longer. Here you just very minimal bend, because you just need some sharp thing to lift it up. You just have to lift up that plaque and then use your forceps. This is my Rexis forceps, which is a multi-use utility forceps for me. And here I use those teeth to just pick on that just lifted plaque and just pull it and peel it, and you really can achieve excellent results.